Okay, maybe we can start.
Yeah, I think so.
Good morning, everyone. I'm Jean Iteboul from Paris, and it's a pleasure to co-chair or co-present this session with Maurizio Cecconi from Milan. So the title is how to integrate the variables in a hemodynamic variable in a patient with shock or something like this. So we try to give you some ideas about how we do. And maybe I have a short presentation, I hope a short presentation on a simple algorithm. And maybe we can apply this to a clinical case if Maurizio, if you have.
Yeah, we can do that. We can hear your clinical cases.
Our opinion about this. Okay, we start. So first, we have to say that in critical patients, in patients with shock, we have intrication of many mechanisms responsible for shock. And this is what is difficult, in fact. As you know, we have many times hypovolemia, vascular tone depression, myocardial depression. And for this, we have three categories of treatment: fluids, vasopressors, and inotropes. Not very original. But the issue is to assess the degree of each component and to select the most appropriate therapy. And importantly, to assess the response to treatment. And also to look at the complete picture of the patient, the presence of other organ dysfunctions, ARDS, acute kidney injury, etc. So we have many variables, and sometimes it is very complicated to identify which is important and which is not. So I want to propose you a very simple algorithm. First, the first step is to identify shock, the presence of shock. The usual signs are hypotension, or mottling, and now you can score the mottling, and you can have some different scores of severity. Increased capillary fill time. Capillary fill time is also a good index of hypoperfusion, and it is a quantitative measure. We can discuss a lot about this, but it is possible to do this. And hyperlactatemia, which is a classical marker of shock, even if there are some other reasons to have hyperlactatemia. Nevertheless, this is the first step, identification of stop. But these markers are also endpoint of resuscitation. And I will show you some other markers which are not endpoint of resuscitation, which are just tools to improve the patient. But these triggers, I would say, these markers of shock are also the markers, the endpoint of resuscitation. Normalizing lactate now is not recommended as a measure. It is better to try to decrease lactate, but also to take into account capillary fill time. Okay. So for this, we have 5 things to do at the same time. Clinical assessment, of course, mottling, skin temperature, capillary fill time, etc. Lactate measurements to follow over time what is happening. Echocardiography as soon as possible. And arterial catheter and central venous catheter if the patient is in shock. So the second step after identifying shock is to start a fluid bolus. Essentially in septic shock, but in almost all categories of shock. But at the same time, you have to check the organ perfusion pressure, which is the difference between MAP and CVP. MAP being the upstream pressure for organ perfusion, for example, the kidney, and CVP, a reflection of the downstream pressure. And some papers like this one, Maris Osterman and co-workers, show that this mean perfusion pressure, MAP minus CVP, but not MAP alone, was an independent marker associated with acute kidney injury progression. And they found a cutoff value of 60. So we can put this in mind, even if we should not strictly look at numbers. Nevertheless, this can give you an idea of what to do. Not only MAP, MAP minus CVP. So if I take the example of MAP of 70, which apparently is good, but if CVP is 15, the difference is not enough. So, if this difference, MAP minus CVP, is less than 60 or around, try to decrease CVP if it is high, but in shock it is very difficult to do this, except if you manipulate the mechanical ventilation, trying to decrease a little bit tidal volume and PEEP in order to have less impact on CVP. Otherwise, in the majority of cases, you have to increase MAP by a vasopressor here, especially if diastolic arterial pressure is low, because diastolic arterial pressure is a good marker of vascular tone. Then, if shock persists in spite of your fluid bolus, if shock persists in spite of giving vasopressors based on this very simple reasoning, it is time to check SCVO2 because you have a central catheter and it is easy to withdraw some blood and to look at SCVO2. SCVO2 is a good marker of the adequacy of oxygen delivery to oxygen consumption, and it reflects in real time the balance between oxygen consumption and oxygen delivery. So we have three possibilities. Either SCVO2 is low, I would mean less than 70%, or between 70 and 80, or higher than 80. If it is low, you know that you have something to do in terms of oxygen delivery increase. There is something to do. Because it is inadequate. This is something we said with some colleagues from the Isicem. And this should incite you to increase oxygen delivery. Try, at least to try. How to do? Of course, there are two possibilities. Either it is due to low hemoglobin concentration, and you have to consider blood transfusion, or it is due to low cardiac output, or inadequate cardiac output, I would say. And it is normal to try to increase cardiac output. I told you that you have to perform as soon as possible echocardiography, at least to eliminate low contractility and the need of an inotropic drug, for example, and dobutamine, for example, or it could be a problem of preload, but you need to, at that stage, not at the earlier stage, you need to assess preload responsiveness, because we know that after some time the patient can be preload unresponsive. I don't want to go into details, it's not the topic today. We have many tests, many dynamic tests, and using the Frank-Starling mechanism, and we have passive aggressing anti-spectral oxygen tests, we have PEEP tests, we have analysis of the respiratory variation of pulse pressure or stroke volume, you have a tidal volume challenge. You can do whatever you can, what you want, it is whatever it is possible in this given patient. And if the patient is preload responsive, and if there is no severe ARDS, so we are in the situation where the patient is still in shock, low SCVO2, fluid responsive, No ARDS, it is logical to try to give another fluid bolus. It is the minimum what we can do, and reassess after. If there is an associated ARDS, it is more tricky because there is some risk of fluid administration, and you have to assess always a benefit-risk ratio before considering another fluid bolus. You have to assess the benefit by looking at the severity of shock, of course, and looking at the degree of fluid responsiveness. Not only the presence, but the degree of fluid responsiveness. It's not the same story when you have an increase in, in cardiac output after passive leg raising by 35% or 11%. Both are fluid responsive. In the first case, probably more. And probably it is more urgent to give fluid than in the other case. And the risk, you can take whatever you want. You can take PF ratio. You can take lung water if you measure extracorporeal lung water. You can take B lines if you use lung ultrasounds. You can take whatever you want, but you need to assess this risk anyway. And, okay, I will skip this. And you have two possibilities, as always. The benefit is assumed to be higher than the risk. It is your brain. Because you consider all the variables, and finally you decide. I consider that the benefit is superior to the risk, and I will try another fluid bolus, and to reassess, of course. Or I consider that the benefit is less than the risk, and I will see other therapies. Now, if you have a SCVO2 between 70 and 80%, what to do? Exactly, delta PCO2 gap. Because in this situation, there is probably an alteration of oxygen extraction. We are in shock, plus a normal value of SCVO2. Probably you have alteration of oxygen extraction. And sometimes it is difficult to know if we have to give another increase in cardiac output. And we look at PCO2 gap. We can give you the solution. If PCO2 gap is, because PCO2 gap is less affected, PCO2 gap, which is the difference between the PVCO2, measured as a central line, and PaCO2. It is a marker of the adequacy of cardiac output to the metabolic conditions. It could help when SCVO2 is the normal range. This is what we said with other colleagues from the Isicem. And if it is more than 6 means that it is higher than normal, and especially when it is 9, 10, 11, 12, it means that cardiac output is totally inadequate and we have to do something. We need to try to do something for cardiac output. And you redo the same reasoning. If PCO2 gap is less than 6, it is probably the worst situation. Because you have a patient in shock with a normal SCVO2, meaning alteration of oxygen extraction, and normal PCO2 gap. In these conditions, you have nothing to do, no benefit expected from hemodynamic therapies. What to do? It is time to reconsider, rethink your strategy. Maybe you missed something. Maybe there is an abscess which is not drained. You have to control the source of infection. You have to rethink about your antibiotics. Maybe this is not the good antibiotics. You have to look again at this, etc., etc. You have to consider your strategy. And now, if you check appropriateness of anti-infection treatment, etc. And if SCVO2 is above 80%, it is also probably the worst situation because it means that there is no extraction at all. And if it is not necessary to increase cardiac output because it will not go to the tissues anyway because of the alteration of oxygen extraction. And again, you have to think about your strategy. And sometimes as you know, the patient dies. And the patient dies many times because he's in this situation. So this is what I wanted to say. We have still 14 minutes.
Yeah. Can we have the other set of slides, please? Thank you, Jean-Louis. But Jean-Louis, really, in 2024, with all the trials negative on SCVO2, are you still using SVO2?
Yes, because, you know, SCV2 was popular since the paper by Rivers, published in 2001, showing that an aggressive therapy based on SCV2 and with a target of 70% was associated with an improved survival. It was a single-center randomized control trial, and the patient had a very low SCV2 at baseline, 48, 49%.
So let's see if it works. Maybe.
Yeah.
So you are coming to the endover in the morning. There was a junior staff member at night yesterday. You are asking, so did you admit any patients overnight? I say, yeah, I got a patient from the respiratory ward. He didn't look right, but he's okay. He's still talking to me, and he's in bed 3. And so you want to go and see bed 3. He's a 71 years old, relatively fit and well. He had an MI about 5 years ago, for which he got stented. He's on the usual blood medication for the heart, and he plays golf, so relatively fit. In the last 2 days, a bit of coughing and so, admitted to the respiratory ward, and then he was not right. So, from what you say here, are you happy or you're unhappy? You're very unhappy, right? Do you need a blood gas? You want a blood gas, but you don't need a blood gas to define that this patient is in shock, right? Do you need echocardiography here? No. So what is striking? What is very bad? Everything. Yeah, I agree with you. So, but the skin is very important, and Professor de Boer was already saying this. Don't forget, touch your patients. The toes, the legs, the core, you know, how this temperature change. There is even some science behind it, you know, difference in temperature between periphery and the center. They can tell you if the cardiac output is likely to be low or high. That's not enough, but it is to look at. And then capillary fill time, which is crazy. This patient is super sick, right? So if you find this patient in your unit and they haven't done much, now it's time to work with the patient. Then you're going to speak with your junior doctor, right? So we talked about this. Let's go fast because I want to see how we will do something on this patient. So, okay. So this is the first chest X-ray you take that you done, and then this is the first blood gas. The arterial blood gas is a pH of 725. The PO2 of 50 millimeters of mercury, PCO2 is 25. The arterial saturation is 78. And the lactate is 5. And because we have a central line in place already, we've also looked at the SCVO2. So the SCVO2 is 43%. So is this good, bad? Is it high, low? Who wants to tell me? Who wants to help me? Maybe there's anybody tries? It's not an exam, huh? I think you want to say something. So what is 43%? Is 43% low? And that's yes. Okay.
But
is appropriately low or inappropriately low? Inappropriately low. Okay, that's interesting. But I think Jean-Louis was telling us that SCVO2 depends on the balance between delivery and consumption. So that's a balance there. But for the delivery, we have hemoglobin, we have arterial oxygen saturation, right? How is the arterial oxygen saturation now? It's low. So it's 78%. So if I would find an SCVO2 of 70%, I would be actually even more frustrated and scared than finding 43%. Now, it doesn't mean the 43% is good. Okay? So we always look at this in terms of arterial oxygen saturation. But maybe there is something that we can do with these two numbers. Maybe Jean-Louis can help us. I know he likes this mathematics.
No. I mean that you have more or less 20%, which is explained by the fall in oxygen saturation. So in your mind, it's not 43, probably around 60%.
So if you want to do some maths, you can even do, you take 78 minus 43, which is basically 35. And if you divide that by 78, that would be your extraction of oxygen. Okay, so the extraction actually is a bit too high here. And Jean-Louis made it very simple. Just take away what you're missing from the 100%. If we're on 63%, that's low. It means that the patient is doing everything to survive, so he's extracting as much as he can. But we enter in that phase where we know that the consumption of oxygen in the tissues depends on the delivery. Okay? Because if you think about it, if we could just extract everything, we would not need to increase our cardiac output. You can go very low and still utilize oxygen, but that's not the case with physiology. At some point, the extraction reaches a limit of compensation and basically your cells switch off and you cannot consume oxygen. So, bottom line, we knew that this was low, and it is actually very low. It means they were not delivering enough oxygen and the patient is not able to compensate there. So, what would you do next? Give oxygen? Yeah, whatever we're giving, we're not giving oxygen appropriately at the moment. I like that, and I think it's important because we do lots of things together. It's not just one at a time. So let's leave it there for a moment. You're probably thinking to give oxygen how to this patient? He's not intubated already, eh? So maybe you start some Optiflor, increase the oxygen. So you are thinking of intubating that patient, right? Let's be honest. Who is thinking of intubating? That this patient will be intubated in the next hour. Yeah? Okay, good. Very good. But, okay, first step, the echo. Okay, the echo is busy in another box and is coming in 15 minutes. So in 15 minutes we come back here. A fluid challenge, okay? I like that. So oxygen, let's increase what we can do, Optiflow in the meanwhile, and then maybe let's get ready for that intubation, but we talk about intubation soon. Jean-Louis, how do we give these fluids? Because Jean-Louis, you told us, in this moment, I like what you always say. This is not the moment to look very clever, right? You just have to start giving some fluids.
Yeah. Yes, I would have started fluid in this case, and another thing.
Okay. So this is interesting because what is the other thing that you would start? Norepinephrine. Would you start it immediately or shall we see the response to fluids? Immediately. Very good. I like that. You know, 10 years ago, we were still debating very much, well, let's give fluids because maybe the vasopressor is not good, maybe the patient had an MI before, it's rubbish, right? So we can do two things together, and this is even more important in this case, we will discuss soon. So if we go... So we are asking our nurse to start a norepinephrine infusion. But let me ask you a challenging question. If you find the same clinical situation, so the patient is the same, but you didn't put a central line yet. Peripheral? Would you put peripheral norepinephrine? We love Jean-Louis, it's great. So people actually have come to our lectures in the last 10 years.
Yeah.
The practice has changed.
We have nothing to say now. Maybe you can give the lesson. Yes, exactly. We can do this in the literature. Now we have a lot of studies showing that peripheral administration of norepinephrine is not associated with harm. No, really, extravasation of the drug. No necrosis, skin necrosis, etc. A lot of studies show this. So it is safe to do this until you insert a central venous catheter.
Do you want to comment, because you explained that very well, why, just from looking at a couple of variables at the beginning, you were thinking about norepinephrine?
Yeah, maybe we can go back.
Yeah, it's one of the first slides. Sorry, there is a bit of lag on the...
I know. Yeah.
Okay.
You have 75, 38, and the mean value is 51. So the mean value is not enough, for sure. We have to do something. Also, what is interesting is the difference, 75 and 38, is not so high. Pulse pressure is not so high. Probably we have something to do in terms of increase in stroke volume. This is why it is logical to give fluid anyway.
So remember, the pulse pressure, it's directly proportional to stroke volume. So many of the algorithms, if the systemic resistance that they are estimating don't change, if the pulse pressure changes, the stroke volume will change in the same direction. Okay, so this is a very easy surrogate, at least at the beginning, to think so.
At least at the beginning, yeah. Exactly. And the diastolic is low. Heart rate is high, and diastolic arterial pressure is low. What does it mean? It means that the vascular tone is altered, is depressed. Normally, with a high heart rate, we should have a higher than normal diastolic arterial pressure because of the reduced diastolic time. And in this case, it is the opposite, to have a low diastolic arterial pressure, which means that arterial tone is totally depressed. So we need to give something to vasoconstrict the patient.
So we have only 5 minutes, but that's a great explanation, Jean-Louis, as usual. We start to think about the fluids. The topic of today is not how to give fluids. We can talk hours on that. But what we like to do when we decide to do is to standardize it a bit in our teams. We like to do 4 milliliters per kilogram in 10 minutes, 250 mLs. Some people do 500, maybe in 15 minutes. I think it's important that you find a small bolus in a relatively short period of time. And remember that the SCVO2 depends on many things. So if this patient had also a hemoglobin of 5, I would have transfused this patient. And especially when you look at hemoglobin and cardiac output, it's not a linear relationship, which means that at the very beginning, when they're very low, you get the biggest gains in the improvement and rebringing the balance there, okay? So that's why I also agree with you. Looking at that pulse pressure, it's probably very likely to be low. And sometimes we don't have time to check, because I'm thinking already of putting a cardiac output monitor here, but I need to stabilize the patient while I do it, right? The oxygen demand is something we don't think about often, but it is part of the oxygen balance of our patients. So in this case, everyone is saying we need to put this patient to sleep, right? We need to intubate this patient. We are removing work of breathing, which in a case like this, it can be up to 60% of your total oxygen consumption. And basically, it is integrating variables, and it is thinking about an hemodynamic approach here. The only thing, we have to be careful about not killing this patient when we put him to sleep, right? And I just want to say, of course, we do the echo. We have the last few minutes. I just want you to think and maybe to help me to realize why the intubation is important here, but what we are going to do in order to prevent a crash, and what is the mechanism to prevent a crash there. So, in a way, you already said that. So what we are doing fluids, but we are doing something else, which is the norepinephrine, okay? In a situation like this, sometimes you don't have hours to stabilize this patient. So the norepinephrine, even in a peripheral line, it's very important for two reasons. It's raising the blood pressure, but we think sometimes in a physiology that is very artery-centric and very cardiac-centric. What the norepinephrine does, if the patient is vasodilated, is also recruiting unstressed volume into the stress volume, as Guyton was teaching us. And so therefore we are increasing the stress volume, and one of the driving pressures for the venous return. So we are recruiting the circulation. It is the fastest way to basically to stabilize and to buy a little bit of time. It does not mean that we don't give fluids later, but in a situation like this, I would be very upset with my team if we don't think about putting an infusion of a vasopressor before we do anything else, right?
It can make more effective fluid resuscitation because of the constraint of the unstressed blood volume.
So we've given a couple of liters of fluids. We put the patient on the ventilator. We were doing that with norepinephrine and so on. We gave a bit of time to stabilize. So let's do the first arterial blood gas 1 hour after stabilization, after we work to this patient. So the pH is now 718. The PO2 is 107. The PCO2 is 32. The saturation is now 99. The lactate is not come down yet. The SCVO2 is 71%. And the CVP is 12 with a map of 65. So I think if you have followed the lecture of Professor Teboul, there are a couple of things he doesn't like here. Are you happy? But what can we do? What would you do at this stage? This is real life sometimes, right? We got patients like this. Echo, there is a bit of cardiac dysfunction. So a bit of left ventricular dysfunction is there, but nothing major. It doesn't have massive dilated ventricles or, there. PCO2 gap. Okay. I like that very much. We're going to look at that. But are you thinking to do anything else, or are you already thinking if the PCO2 gap is fine, I will not do anything? Are you already at the stage in your thinking? Maybe, I'm not saying it's wrong, but if I'm in this situation and the lactate is 5.9, the SCVO2 is 71, we've done something, but I wouldn't say that we sorted this patient. Sorry? Yeah, I agree. But are you happy with the goals that we've achieved here? A map of 65 with a CVP of 12? No. More fluids. He wants to give more fluids. She wants to increase mean arterial pressure. I guess with norepinephrine, so we can increase that a bit. Okay. Somebody wants to give inotrope. So we just put everything into a bag and we give everything. So, but this is the dilemmas that we have all the time. I agree with you, by the way. This is the norepinephrine. It's always that accelerator or brake, that you can use fast. While, however, we need to think about, do we still have room for fluids? Maybe. But how would we know now in this situation? And can we find that out only with this basic hemodynamics? I'm not so sure. Monitoring? Hemodynamic monitoring. Yeah, in my practice, this is what we start to think now. Probably I was starting to thinking at the beginning because what we wrote together with Jean-Louis and now we are doing a revision of the shock consensus and monitoring was that if a patient improves fast with your first therapy, you don't need fancy monitoring. If the patient gets better quickly in the first hour or two, it's okay. But this patient is not there yet, right? He looked very sick. And we have data which we didn't show you today, but it's out there, that if I give a fluid challenge now, and I just look at the blood pressure, maybe the cardiac output will change, but I will not be able to see those changes, okay? So I would do the same that you said. I would actually increase the norepinephrine, buy a bit of time. If I have a cardiac output monitor or maybe my echo in the meanwhile, I would like either to predict fluid responsiveness at this stage. If I don't have the conditions to predict, maybe I would still give a little bolus, not 1 liter, not 500, maybe 250 mL, and test my hypothesis, but with a cardiac output monitor now.
I fully agree. It is clear that in this situation now, because the patient did not respond very well to the initial treatment, if you don't use hemodynamic monitoring in this condition, you can forget hemodynamic monitoring for the rest of your life or your professional career. Okay, so maybe we have to stop. I think
we have to wrap up. But I know that everyone wants to know what the PCO2 gap is. Yeah? So let's see if I have it somewhere.
PCO2 gap, yes.
No, I didn't put it. But okay. Yeah, the patient died. But you did a good job.
Thank you very much.